Esse é o SOBEDCast, um podcast da Sociedade Brasileira de Endoscopia Digestiva, onde você ouve bate-papos científicos sobre tudo que é novidade na endoscopia no Brasil e no mundo.
Boa noite, meu nome é Miguel Koury Filho, sou membro da Comissão Científica da SOBED.
Boa noite, meu nome é Vitor Arantes, sou coordenador da Comissão Científica da SOBED.
Estamos aqui com mais um SOBEDcast. No nosso primeiro podcast internacional, teremos a honra de receber a doutora Margaret Zhou, médica pesquisadora da Stanford University School of Medicine.
Doutora Zhou e seus colegas pesquisadores publicaram um estudo muito interessante sobre o papel da pesquisa de sangue oculto nas fezes e o risco de neoplasia no trato gastrointestinal alto.
Em respeito à nossa convidada, esse podcast será todo realizado em inglês.
Okay, so welcome, Dr. Zhou. It's our pleasure to interview you about your paper. Thank you very much for accepting our invitation.
Thanks so much for having me. It's my pleasure.
All right, so we start this interview, first of all, congratulating you and your team for publishing such an interesting paper about the relationship between the FIT test, the positive fecal immunochemical test, and upper gastrointestinal cancer.
Yeah, thank you. I'm so glad that it was able to be published and that there is a good amount of interest in our work. I think it is a really interesting question and an important one, certainly as FIT is increasingly adopted around the world.
Dr. Zhou, as we know, the FIT is well established as a screening test for colorectal cancer. Can you tell us about the role of FIT for colorectal cancer screening in your community or across USA nowadays?
Absolutely. So currently in the United States, the most recent guidelines recommend colon cancer screening starting at age 45. So screening colonoscopy is actually the most common method of colon cancer screening in the United States. However, FIT testing or fecal immunochemical testing is estimated to make up about 30% of colon cancer screening in the United States and kind of varies between different practice settings. So, while FIT is the leading non-invasive colon cancer screening test in the United States, it's certainly, in many countries, actually the primary form of colon cancer screening.
Yes, it's interesting because we all know the FIT test is closely related to the risk of lower GI cancer, large bowel cancer. So how this idea came to your group of investigators of studying the role of FIT test for upper GI cancer? What led your team to investigate this interesting issue?
Yeah, absolutely. So I think as you're pointing out, as gastroenterologists, we commonly encounter these patients who are referred to us to have a colonoscopy to evaluate a positive FIT. But it's pretty common to have a situation where their colonoscopy does not reveal any pathology that might explain the FIT test. And so, in fact, over half of patients who have a positive FIT do not have either colon cancer or an advanced adenoma on their subsequent colonoscopy. And so this is a really common question. And so, even though FIT is supposed to be more specific for lower GI tract blood loss, there remains the question of whether there might be a lesion in the upper GI tract that could actually explain that positive FIT result. And so the question in the back of our minds can be, should we be performing upper endoscopy in these patients? And so, we really wanted to try to help answer this question because in part, current US guidelines do not support upper GI tract evaluation after a positive FIT with a negative colonoscopy. And really optimal management of these patients is not very clear. The evidence supporting guidelines such as the most recent US Multi-Society Task Force guidelines that recommends against upper endoscopy in these patients, this evidence is pretty limited, mostly consisting of small observational studies. There have been 2 more recent population-based studies out of Korea and the Netherlands with mixed results. And so we were really interested to study this question in a diverse United States population.
Okay, very interesting. And what was the methodology you used?
So For our study, we performed a retrospective cohort analysis using the Optum database. Optum is a claims data warehouse that encompasses about 13 million individuals who are annually enrolled in a commercial health plan in the United States across the whole country. And so we identified all patients ages 50 to 61 who underwent first-time FIT testing. And we use these age cutoffs in part because of trying to avoid loss to follow-up at age 65, because in the United States, a lot of patients at age 65 get out of their commercial health insurance and enter Medicare, which is our insurance for elderly folks. And so we categorize patients into either FIT positive, FIT negative, and then we also separately analyzed a small cohort of patients who did not have a FIT test result that was available in the database, just to make sure there were no systematic biases within these groups. And we looked for our primary outcome, which was a diagnosis of an upper GI cancer. For us, that included esophageal, gastric, or small intestine cancers within 3 years of FIT. And the way that we assessed for this outcome was using ICD codes. And really, our aims were to first evaluate the risk of upper GI cancers between FIT positive versus FIT negative patients. And second, we wanted to compare the risk of upper GI cancers among those FIT positive patients who did or did not have colorectal neoplasia that could potentially explain the positive FIT result.
Well, very interesting and very sophisticated methodology. So could you share with us the most important and remarkable findings of your investigation?
Yeah, absolutely. So for our cohort, we were able to identify about 153,000 patients who underwent a first-time FIT test in Optum. About 6% of these patients had a positive FIT test, 80% had a negative FIT test, and then there were 14% who did not have a FIT result available in the data set. And so in total, we had 127 patients who developed an upper GI cancer within 3 years of the FIT test. And so that made up an absolute risk of 0.08% of our entire cohort. Then breaking this down by FIT result, we found that the prevalence of upper GI cancers in the FIT positive group was 0.25%. In comparison, the prevalence in the FIT negative group was 0.07%. And so the 3-year relative risk of upper GI cancer comparing the FIT positive versus the FIT negative group was actually 3 times higher. We then broke down the FIT positive group into those patients who did have colorectal neoplasia. So that was either a colon cancer or a polyp that was identified by ICD codes. And this was to help us understand how the presence of colorectal neoplasia might impact the risk of these patients having an upper GI cancer. And we actually found that the 3-year risk of an upper GI cancer in those FIT positive patients who had a colorectal neoplasia was 0.40%. So actually a bit higher. And in comparison, the risk in those FIT positive patients who did not have colorectal neoplasia was 0.19%. So among those patients who did have colorectal neoplasia in the FIT positive group, that risk was actually about twice as high. And so this was a bit surprising to us. Our initial hypothesis had been that the risk of an upper GI cancer might actually be highest in those FIT positive patients who did not have a colorectal neoplasia that would explain that positive FIT test. And so we actually found that upper GI cancer risk was actually highest in those patients who also had colon pathology. So that was a pretty interesting finding. And then we wanted to further strengthen our findings with some more analyses. We performed an adjusted Cox regression to try to determine the association between FIT and the risk of upper GI cancer. So we adjusted for multiple possible confounders, including age, sex, race or ethnicity, presence of a colorectal neoplasia, and we also actually included upper GI alarm symptoms or signs that potentially might impact our results. And we found again that a positive FIT test was an independent predictor of upper GI cancer risk with a 3 times higher adjusted risk of upper GI cancer compared to negative FIT. And then in addition to that, we found, again, this association between colorectal neoplasia and prediction with upper GI cancer. So kind of our initial preliminary findings were reinforced with our adjusted analyses. And finally, the last result I want to highlight from our study is that we performed analyses stratified by race or ethnicity, since there are many risk factors that could potentially predispose within ethnic groups to upper GI cancer risk. And again, positive FIT was an independent predictor of upper GI cancers in white, Black, and Asian American patients. However, we did not actually find this to be the case in Hispanic patients.
Very, very interesting. And what do you think is the potential influence of our findings in the future of upper GI cancer screening? Do you think that at this moment, it's reasonable to say that everyone with a FIT positive deserves an investigation on upper GI tract?
So, I wouldn't go so far yet, but I do think our results are interesting, and I hope will encourage other people to investigate this question. Certainly one of the limitations of our findings was that our absolute risks were really quite low. And so with that, low amount of absolute risk, I don't think we can encourage people to, perform simultaneous upper endoscopy and colonoscopy at this moment. But I really think that as FIT continues to be adopted around the world, there may be lots of opportunities for other investigators to pursue this question prospectively. So we can really try to more definitively understand what is the risk of upper GI cancers in this large cohort of patients that are undergoing FIT testing for colon cancer screening. And because we're already using FIT for colon cancer screening, this could potentially be a good opportunity to try to improve our screening and early detection of upper GI cancers too. There have been some accumulating observational data the past few years that do support our findings. And so, I hope that other investigators will remain curious about our question and continue to look into it as well.
Well, very interesting. And would you tell us when do you expect the final publication of the paper, or have you already published it finally? Or because I thought that we had just the online version or first print version. Is it already published for the public to access your manuscript?
It is available online on clinical gastroenterology and hepatology. I think that the finalized version will probably come out in a few months, both probably in the paper, in the print journal, as well as online in their website. So I think, look out for that in a couple months.
Okay, so it is very interesting paper. I'd like to congratulate you and your co-authors. And could you give to our audience a final take-home message from your paper and what we can expect in the near future about the results of your investigation? And also, I'd like to highlight that your paper has received a lot of interest from many people. So, would you give a final take-home message for everyone, please?
Yeah, absolutely. So, I think really the take-home from our paper is that in these patients who we are screening for colon cancer with FIT testing, we found a higher risk of upper GI cancer in these FIT positive patients that may be up to 3 times higher compared to negative FIT patients. And when looking at stratifying by presence of colon cancer or colorectal neoplasia, in spite of our expectation that perhaps those FIT positive patients who don't have colon pathology may be at highest risk, it may actually be that those patients who have colorectal neoplasia may actually be at highest risk. And so, based on our findings, when encountering FIT positive patients in our clinics, I think you may consider doing an upper endoscopy either simultaneously with the colonoscopy or after a negative colonoscopy, kind of depending on the risk factors that a patient may have presenting to you. So I would really encourage clinicians to really consider obtaining additional history from a patient about upper GI symptoms or a family history of GI cancers that could potentially help to risk stratify patients who are FIT positive. And I think kind of moving forward, further research to really help determine which of these FIT positive subgroups may best benefit from simultaneous upper endoscopy and colonoscopy is really the next step. So trying to identify additional risk factors. We've seen here that colorectal neoplasia may be one, potentially looking into certain symptoms, lab values, other potential risk factors that could help risk stratify these patients may be helpful.
Okay, so I will give a final words in Portuguese to our audience. And again, I'd like to thank you so much for this very nice interview. Então, esse foi mais podcast da SOBEDCast. Dessa vez tivemos a honra de entrevistar a doutora Margaret Zhou, que lidera grupo de pesquisa da Universidade de Stanford. E como vocês puderam ver nessa entrevista, muito interessante. A pesquisa de sangue oculto nas fezes positiva, mostrando não apenas o risco de câncer coloretal, mas também o risco de câncer no trato gastrointestinal alto, independente do sexo, independente da idade do paciente, independente do tipo racial e com detalhe, se o paciente tem câncer coloretal ou não tem câncer coloretal, esse risco também foi observado. Então fica a mensagem da doutora Zhou para se considerar eventualmente a endoscopia digestiva alta junto com a colonoscopia como uma investigação nos pacientes com teste FIT positivo. Esse foi o SOBEDCast e eu gostaria de pedir ao Dr. Miguel Koury para fazer o encerramento desse nosso episódio.
Queria agradecer, Dr. Zhou. Thank you, Dr. Zhou, once again for accepting our invitation. I hope we can count on you in next future projects too.
Thank you. Yeah. Thank you so much for having me. It was really my pleasure.
Obrigado a todos. Esse foi mais um SOBEDCast.